Hi, I'm Bobby Pritt, Director of the Clinical Parasitology Laboratory and Vice Chair of Education in the Department of Laboratory Medicine and Pathology at Mayo Clinic. In this month's Hot Topic, my colleague, Dr. Brad Karen, will discuss the need and evidence behind following the order of draw recommendations for routine blood collection, specifically addressing whether the existing evidence demonstrates a need to collect serum tubes before either potassium EDTA or citrate tubes. I hope you enjoy this month's Hot Topic, and I want to personally thank you for allowing Mayo Clinic the opportunity to be a partner in your patient's health care.
Thank you, Dr. Pritt. To those of you who have not attended a phlebotomy conference in the past, the title of today's session, Top Gun Phlebotomy, may seem a little odd. I hope I'll be able to explain to you what is Phlebotomy Top Gun all about and what we do at our annual phlebotomy conference. I have no disclosures relevant to today's presentation. Every year at our phlebotomy conference, I present a talk that's always called Phlebotomy Top Gun. The format of Phlebotomy Top Gun is a case-based presentation. I solicit from attendees of the conference the questions, issues, areas of concern that they would like to hear about. Using the questions submitted by the audience, I present these as case-based scenarios. Using an audience response voting mechanism, the attendees of the conference vote on what they believe the correct answer to the case or question to be. I then present the collective experience of the Mayo practice as well as any published data and evidence I can find. At the end of the case presentation, the audience votes again. For each case, I can see whether I've been able to change anyone's mind on the question and issue by presenting the data, evidence, and information relevant to this particular topic. This is an actual case from last year's Phlebotomy Top Gun presentation. In last year's presentation, we were addressing the issue of order of draw and whether the order of draw is still relevant in today's modern phlebotomy practice. So the question I posed based on a question submitted by a conference attendee last year was the following. Which of the following statements describes the importance of drawing the serum tube before a potassium EDTA tube? 1. In the area of lyophilized anticoagulants, the order of draw is no longer important. 2. Contamination of serum samples with potassium EDTA will occur routinely if the order of draw is not followed. 3. During syringe collections, contamination with potassium EDTA may rarely occur if the order of draw is not followed. Or 4. Modern lab equipment can tell the difference between potassium from an EDTA tube and potassium from the patient, so order of draw is no longer important. At this point of the phlebotomy conference, attendees will vote on what they believe to be the right answer. At the end of the case, we'll repoll and I'll reveal what I believe to be the right answer, and I'll get to see if I've changed anyone's mind. A great number, but not all cases, start with a review of the CLSI Guidelines, which have a great deal of information about the recommended procedures for blood collection. The relevant guideline in this case, as is often the case, is the GP41 Collection of Diagnostic Venous Blood Specimens guideline from the CLSI. In the guidelines, they go over order of draw recommendations, which continue to be present in the guidelines as blood culture first, followed by citrated tubes, serum tubes, heparin, then EDTA, with a special emphasis on not collecting the EDTA tube before the serum tube. The guidelines do clarify that although these recommendations are valid for both liquid anticoagulants, glass tubes, which are really not used other than a few special coagulation type tests in our practice, and the more commonly used plastic tubes that have lyophilized additive in them. The guidelines go on to say for additives not listed that you consider the type of additive and where it fits into the order of draw. The guidelines suggest not collecting serum clot activator tubes before a citrated tube for coagulation study to avoid carryover of the clot activator into the coagulation tube. And they specifically mention in the guidelines that sodium carryover from sodium citrate or sodium heparin tubes into a serum tube is not really significant. And then for trace metals, follow the manufacturer's instructions for various tubes and collection devices. So that's a review of the CLSI guidelines. Again, that's where I start with many of the cases presented or questions presented in a phlebotomy conference, we start reviewing CLSI guidelines. In the case of order of draw, this is one of the rare situations where we have a CLSI guideline to consider. We also have this European Federation for Clinical Chemistry working group on pre-analytical phases of testing that really did an extensive review, and I have references at the end of this presentation for those of you who like to read it. But this European group really did an extensive review and had a consensus conference on a number of pre-analytical phases or pre-analytical questions about blood collection. This document goes on to list various problems that have been linked to incorrect order of blood draw, including hypernatremia due to sodium citrate and sodium EDTA, which, if you'll recall a slide ago, the CLSI said it was not an issue. The European Federation suggested it could be an issue. Hyperkalemia due to potassium EDTA contamination, that's really what we're going to focus on, is potassium contamination from potassium EDTA tubes into serum. Hypocalcemia, low magnesium, zinc, alkaline phosphatase, other enzymes, again due to EDTA contamination of serum tubes. Poor coagulation due to transfer of anticoagulants, clot activator, for example, into citrated tubes. Clot activator interference with coagulation test I mentioned, and dilution effects if you pour one tube into another. These guidelines then went beyond what CLSI has done, which provides you guidelines for what you should do and a few references. But this is, again, I encourage people to read this, a very nice document to go into, well, why is this important, or basically what are the mechanisms of potassium EDTA contamination and how much evidence exists that they do or don't actually happen. They went over 3 potential mechanisms for anticoagulation contamination for potassium EDTA contamination of serum tubes when the order of draw is not followed. Direct transfer or pour-off, again, obviously if you need serum, you collect potassium EDTA and you pour that into a serum tube, you're going to have a contaminated sample. Obviously a very bad practice, and we don't expect to see that where we have trained phlebotomists. Backflow during closed loop or vacutainer collection. So if you snap the potassium EDTA tube onto the vacutainer adapter, there's a potential for some blood that has potassium EDTA on it to stick to the vacutainer adapter, and that could get transferred into the serum tube. We're going to show you in a minute that studies really don't suggest this actually happens with lyophilized potassium EDTA. So this is what may have changed, going to plastic tubes with the lyophilized reagent, lyophilized anticoagulant. We don't see that there's carryover from backflow on a vacutainer adapter. And then contamination by syringe. So if you use the syringe to dose the tubes in the incorrect order, so dosing the potassium EDTA first, then the serum, there's a potential to carry over some of that potassium EDTA from the purple top potassium EDTA tube to the serum tube. Data on this, whether this really happens and how often this happens, is somewhat spotty or controversial, but that's really what we're going to talk about. If this doesn't happen anymore, maybe order of draw is no longer important. However, in general, what the European Federation for Clinical Chemistry, this pre-analytic work group, concluded is order and draw was not important for routine venipuncture using a vacutainer adapter, but that contamination still did occur during syringe transfer, and because it did, rather than training one way for routine vacutainer and another for syringe, it was easiest to follow the order of draw as defined in CLSI guidelines and by this guideline group all the time. These studies are really those cited in the European Federation Working Group document. One study of 11 healthy volunteers drawn by experienced phlebotomists. In this experiment, they drew a serum tube, potassium EDTA tube, then a second serum tube, and just tried to measure in a healthy outpatient using experienced phlebotomists, was there any measurable EDTA carried over from that middle tube into the second serum tube? Well, the answer was no. EDTA was not detectable in any of the serum samples, and looking at the measurements that would be affected by potassium EDTA contamination, potassium obviously, and then the metals, calcium, magnesium, zinc, and the enzymes that need calcium and metals like alkaline phosphatase, there was no difference between the serum tube drawn before the EDTA and the serum tube drawn after. So it's a small study, 11 healthy volunteers, but really didn't find that contamination occurred when you drew an EDTA tube before a serum tube. A little bit larger study here cited 57 outpatients attending an anticoagulation clinic and 58 healthy volunteers. So now we're getting to 120 or so patients involved. Multiple experienced phlebotomists, again, outpatients, volunteers, drew a serum, then a citrate, then a second serum, and another set of volunteers drew a serum, a potassium EDTA, and then a serum. And again, the similar results. There's just no difference between the mean potassium, sodium, calcium, magnesium, phosphorus in the serum collected first and the one collected after either an EDTA or a sodium citrate tube. Consistent with the smaller study I just showed, really showing that order of draw probably doesn't matter in routine outpatient phlebotomy using a Vacutainer adapters. We're not seeing carryover between tubes. In contrast, here's a study that was done on hospital inpatients in one UK hospital. And for 1 month, they simply said, well, let's look at all inpatient blood serum potassium where the potassium is over 6 millimolar. And let's just see if we can detect measurable EDTA in those. So they had 117 samples with serum potassium over 6 millimolar. And 25% of those had detectable EDTA over 0.1 millimolar per liter in this study. So that would suggest that carryovers fairly frequently, just again, selecting for serum samples with high potassium. We're seeing a lot of these samples, almost a quarter of them, have some amount of EDTA that presumably had to come from a potassium EDTA tube. There's not a other logical explanation for where EDTA in a serum sample would come from. Again, most of these were inpatients, and almost all of these patients, when they had potassium measured a second time, it started over 6, it returned normal and had no EDTA. So again, further evidence that this was likely potassium EDTA contamination in these patients with high potassium serum values. EDTA concentration, all of these had measurable, but the more EDTA, the higher the potassium, the lower the calcium and zinc and magnesium and alk phos. So more evidence that what they're seeing is a variable amount of potassium EDTA getting into serum samples somehow. The study didn't say how it got there, it just showed it got there and that it caused high potassium, low calcium, magnesium, zinc, and alk phos. This same group of authors went on to do a multicenter study to say, well, this was this one UK hospital. Let's look at 5 hospitals. And these hospitals were all in the UK as well. But look at 5 different hospitals over a month. Again, very similar idea. Let's look at all serum potassiums over 6, and let's see how many of those has measurable EDTA to see if this was a fluke. You can see they looked at different types of tubes, Sarsted versus Greiner, and one site had BD. Each site had between 100 and 300 of these serum samples with potassium over 6. And then you can just look at the last column, the percent that had EDTA contamination. It varied from like 1% to almost 7%. That very first study showed almost 25% of these serum samples of potassium over 6 contaminated with EDTA. Here we're seeing it still happens, but lower numbers, sort of 1 to 7% of these serum samples with high potassium are contaminated by potassium EDTA. What's our experience been like here at Mayo Clinic? We also do a similar thing. We have a number of rules built into our middleware system in the lab to detect possible contamination with either potassium EDTA, IV fluid, but specifically there's a flag that goes if the potassium is over 6 millimolar on an inpatient, and then it'll look at other values that are requested with that potassium and alert for potential contaminations. When this flag goes off for potential contamination, caregiver is contacted. If this value is not expected for the patient, we'll redraw it, and most of the time we find that potassium comes back relatively normal if it's a contamination suspected. Most of the time, that potassium contamination is from potassium given intravenously to the patient, not suspected to be potassium EDTA. Unusual cases are reviewed. They go to a resident or fellow on call, and then we review those weekly in our call rounds. And it seems like between once a quarter or once a month, have a sample with a very high potassium that doesn't look real, and oftentimes a resident or fellow will say, If they didn't order a calcium or magnesium, can we measure one to see? And it'll come back similar to the studies that I showed, with a very high potassium, a very low calcium or magnesium. It'll be redrawn with a normal potassium, and it'll look like potassium EDTA contamination, similar to the studies I showed. So we don't exactly know. Again, we don't go back and we don't always know, was it drawn with a syringe or a vacutainer. We suspect what we're seeing here is what's been shown in other studies, some low rate, 1%, 5% of these very high serum potassium samples have somehow been contaminated with potassium EDTA. We suspect during syringe draws that were done, improper order of draw was followed, so the potassium EDTA tube was dosed first and then the serum tube. Conclusions for order of draw. Evidence suggests that potassium EDTA contamination does not occur when you have a closed draw, that is a vacutainer needle and vacutainer adapters with plastic tubes and lyophilized potassium EDTA. It doesn't really look like this backflow is still happening, that potassium EDTA gets stuck to the vacutainer adapter and goes into the serum tube if it's drawn after an EDA tube for a vacutainer collection. The greatest data on syringe draws comes from these 5 UK hospitals, the study I showed. Potassium EDTA contamination is seen in somewhere between 2 and 15% of all samples that had very unusual potassium, calcium, magnesium, or zinc concentrations. I want to make clear, it's not that 2 to 15% of all serum samples are contaminated with potassium EDTA, but when you select for something like potassium over 6 or very low calcium or magnesium values, then you see that 2 to 15% of those samples do appear to be contaminated with potassium EDTA. So it seems that order of draw is still important, and that with syringe draws particularly, you can carry over potassium EDTA from the purple top to the serum tube if you do not dose them in the correct order or essentially follow the recommended order of draw. At Mayo Clinic, we are still rarely seeing samples that look like they have potassium EDTA contamination. In our practice, able to figure out, was that a vacutainer or syringe collection? It could be happening more often than we're detecting with our middleware rules and systems. The underlying assumption that I'm left with is that order of draw is still important. You should draw the serum before a potassium EDTA purple top tube. And the underlying assumption from the data and evidence out there is contamination happens primarily with syringe draws. There does not seem to be the backflow contamination with a routine vacutainer collection, but I would agree with the European Federation work group guidelines. If you're going to do it for syringe draws, it's probably just easiest to follow the recommended order of draw for all blood draws. So during the phlebotomy conference, we would then go back and repoll the audience. I've now given our experience, the review of the published data and guidelines that are out there, and we would go back and now repoll our audience the same question: which of the following statements describes the importance of drawing a serum tube before the potassium EDTA tube? And again, the same answers in the area of lyophilized anticoagulants. Order draw is no longer important. Contamination of serum samples with potassium EDTA will occur routinely if the order of draw is not followed. 3, during syringe collections, contamination with potassium EDTA may rarely occur if order of draw is not followed. And 4, modern lab equipment can tell the difference between potassium from an EDTA tube and potassium from the patient, so order of draw is not important. So the first 3 of these are plausible. The 4th I just threw in as a fun answer, that no, our lab equipment can't tell the difference. Potassium is potassium. And we would allow the audience to repoll, and then I would present what I believe to be the answer would be number 3, that order of draw is still important because during syringe collections, contaminations with potassium EDTA may rarely occur if the order of draw is not followed. So that's the end of my presentation, and again, this is a case one of 4 or 5 I presented at last year's Top Gun phlebotomy presentation at our phlebotomy conference. If you enjoyed this presentation, or even if you didn't, I would encourage you to investigate, register for, and come to our Phlebotomy 2019 conference, People plus Performance equals Patient Care. More information can be found on the Mayo Clinic Laboratories websites. These are references for those of you who'd like to read more, and I appreciate your time today.